aching head. Yep, today we're talking about medications for pain relief. And aren't you glad that we have medications for pain relief? Oh my goodness, could we make it through the day without having some Tylenol or some ibuprofen in our life? So let's get working on talking about these amazing drug categories and their availability to us in the public. Learning outcomes, you guys know the drill here. Read through those, you're going to need them. There you go. Okay. Inflammation. So inflammation is kind of like your body's defense system against all things, right? So your body recognizes something, a foreign invader, or recognizes that you had an injury, and it sends out all these mediators to basically to help to neutralize or to help to get rid of these incredible things that should not physically be in your body. So this is basically what your cells look like once the cells have done all their job and they go through and they just have dead parts everywhere. We have to make sure, or the body has to make sure that it clears out all this debris field in order to be sure that it has a nice clean place where it can begin to rebuild and repair. Otherwise, you don't want to build junk on top of junk, right? You want to have a nice, good foundation just like you would have in a home. So whenever I think about inflammation going in to like attack something to start to heal it, one of the things that happens with that is sometimes is pus formation. Well, you know, once we get the pus and that stuff out of there, out of a wound bed, then the wound can begin to heal. The same thing happens with inflammation in our body. So pus is the body's way of removing the debris from the field so that we can begin to have new cells. With our cells, we get these inflammation mediators. So from the mast cell, all these things come. Histamine, leukotrienes, bradykinin, complement, the prostaglandins, they all come from the mast cell. So as the mast cell has identified or has been activated by the body in an inflammatory response, it sends out all these guys to do all this sort of stuff. Histamine comes from the mast cells, kind of gets there, it's the first guy on the job, and its basic job is to kind of help to vasodilate everything so that the blood and everything can rush to the injury. I think about Nemo. Is there any blood rushing to the site? Is there any blood rushing to the injury? That's histamine's job. Okay, and the reason that we do that is we want the blood to get there fast because it's going to bring the good guys, the macrophages, the leukocytes, the eosinophils. It's going to bring all those things to there. So histamine does play an important role in making sure that we are happy and healthy. However, sometimes it goes a little overboard and it doesn't know when to shut itself down. So this is the reason why we have medications that help to block these processes in order to make you, again, happy and healthy. When we talk about inflammation, we talk about two different types. We talk about this very acute onset of inflammation. If you've ever twisted your ankle or been hit by a baseball or been bitten by a mosquito, you see that onset of immediate inflammation. Typically, that type of inflammation will resolve within 8 to 10 days. It goes away on its own. This chronic inflammation is more of a slower process. When I think about someone having chronic inflammation, I think about this pretty lady. There could be inflammation going on all over her body, but we can't see it because it's very slow. True statement. When you go to start cooking a lobster, you don't drop a lobster in a hot pot because it'll try to jump out. But if you put the lobster into the water and then slowly boil him up, he doesn't jump out, even though he's going to die from it. Chronic inflammation is a lot like that, okay? It starts very slow, progressive, until it begins to cause issues. So with those patients, treating them with their inflammatory issues can be a little more tricky, take a little more pharmacology versus someone who has inflammation today. When we think about patients who suffer from chronic inflammation, I think about all of these patients, all of these different types of symbols here. One of the ones that I like to point out that's pretty, you're like, oh, Ms. Hardy, you gotta be kidding me. That's like not a big deal. It's gingivitis. I took a class a couple of years ago all about oral health, and one of the things I learned was the role that the stuff that's inside your gums plays a huge chronic inflammatory process in your body all the time. And so because of that, those patients who have gingival disease go on to have premature births. They go on to have heart disease. They go on to have higher cholesterol. because the body is constantly in an inflammatory state because of gingivitis. So brush your teeth, go to get your cleanings done twice a year, and then see your dentist at least once a year. So we do have some strategies for managing inflammation. Remember, inflammation is not really a disease. It's kind of like the symptom of something else going on. So we need to figure out what that something else is that's going on. So I gave you kind of a list here of things that could be going on. Of course, with any type of inflammation or any type of a drug therapy, if we have a choice between using a non-selective or a selective medication, we want to use a selective medication. We get more bang for our buck. We get taken care of what needs to be taken care of in that system versus treating the entire episode, right? So what I tell my patients is if we can use a topical agent to care for something, then we'll use a topical agent, something that's a little bit more directed. But if we can't use a topical agent, then of course we'll have to use something that kind of affects things a little more systemic. So let's kind of move forward and let's talk about what kind of pharmacological treatments, non-pharmacological treatments we can actually use with these patients. For our non-pharmacological patients, we have something called the RICE acronym. It means you need to rest that part, you need to ice that part, you need to elevate that part, and you may even need to compress that part utilizing a bandage, an ACE bandage, something that's got a little stretch to it. The other thing you can use is you can use a hot compress, cold compress, whichever feels good. Massaging, okay, helps to heal the injured area. Something called stretching, gentle stretching exercises. I provided you a link here to a guy who talks about neural flossing. No, it's not flossing, it's neural flossing, which is basically gentle stretching of the area that helps to reduce pain. And this video in particular deals with sciatic pain. The other fun thing we can use with patients, especially if it's musculoskeletal pains, is this thing called a TENS unit. I have a bunch of athletes in my house, and everyone comes home at night, and I feel like I'm like, okay, it's your turn, and then it's your turn, and then it's your turn. You can buy these at Walmart, Walgreens, or your favorite pharmacy. They run about somewhere between $25 and $45. But basically what you do is you take the little sticky pad off, and you put it on the injury, and you separate the two pads by about 2 inches. And then when you turn it on, it provides electrical stimulation, which interferes with the way that the pain is being perceived. These are fantastic for back pain, neck pain, shoulder pain, leg pain, you name it. These are amazing. And the pads that we buy on here, each pad can go for about 50 different treatments. So it'll last a pretty long time. It takes, I think, two AAA batteries, okay? But a pretty powerful little machine. It's pretty interesting. When we travel on vacation, we take this with us. It's kind of crazy. The other thing you can use for musculoskeletal pain is your over-the-counter products. Here's a couple of my favorite one. This is a gel that you put on top. And again, it does have that wonderful, I'm an old man smell. It's great. And then these are Salonpas patches. These patches tend to not have as many smells to them as the other ones. The only problem that we found with the patches is that once you open the package, if you don't seal those down really, really good, they kind of lose their potency. So you have to make sure that you seal them back very good. And in here is camphor, menthanol, and menthol salicylate. So it's got a little bit of an aspirin in it. So be careful with your small children, with your younger children, and we'll talk more about that shortly. So for our patients who are having this pain, what I need you to understand is that this is how kind of the flow, the process of how we get pain. So you have tissue damage, you have this adrenergic acid that gets released, and then you have two different systems that are then activated. You have COX-1 inhibitors and you have COX-1 and COX-2. These are the two receptors that are in your body. When we activate a COX-1, what we get is we get this gastric protection. And with this gastric protection, your body actually secretes like this slime that kind of helps to protect the inside of your stomach. It actually helps to decrease the acidity of your stomach. We also get platelets kind of start to stick together a little bit better. So that may not be what we want to happen, but that's what happens whenever we activate COX-1. And then we get this renal protection. It actually, COX-1 says, hey, these are my kidneys, you stay away. And then we get a little bit of a vasodilation effect when we have tissue damage. The body vasodilates, again, so we can get the blood to where it needs to be so it can bring in the healing agents. And we get a little bronchodilation. When we get injured, we have adrenonic acid released. We also get activation of our COX-2 receptors. Now, this is really the one where we have these inflammatory properties. We get inflammation, we get pain, we get a fever, and our platelets are decreased. They're not sticking together as well as they would or were before. So if we had a choice between blocking a COX-1 or a COX-2 receptor side, really and truly, if we were trying to just treat pain, we would really and truly only want our COX-2 to be blocked, because that's the guy who's causing pain, fever, and inflammation, right? Well, our drugs, some of them, whenever they were first put into practice, are non-steroidal, non-selective NSAIDs. They actually block both COX-1 and COX-2. So because of that, sometimes when we take these medicines that are over the counter, we get some undesirable effects, okay? And what I mean by that is that we lose our gastric protection, our platelets stick together a little bit, are a little bit further apart, we get renal protection, we lose it, we lose our vasodilation, and we lose the ability to bronchodilate as much. So here's our NSAIDs laid out in a first generation and a second generation. The top three on the first generation, the salicylates, the ibuprofen, and the naproxen, those were all available over the counter. Ketorolac, Meloxicam, and Indomethacin, Diflunac, your book lists some additional ones. Those down there, those bottom four, are the most common ones that you're going to see in practice kind of in our regional area. If you're outside of our area, of course, you're going to see some other ones. There's only one drug in the second generation NSAIDs. It's known as Saloxibid, Celebrex. All the other ones got taken off the market because of their nasty side effects. So with an NSAID, kind of by and large, if we were going to just say, describe to me the most common side effects of an NSAID, these would be them. It doesn't really matter if it's a COX-1 or a COX-2. I know that COX-2 is supposed to be selective and just turn off that branch. Let me tell you a little secret. It's not exactly as selective as they thought it was. All right, we'll get to that in a second. But by and large, all NSAIDs, you need to know gastric irritation. So we always tell patients, if you're taking Motrin or you're taking ibuprofen or Aleve or Meloxicam or Toradol, if we're going to take an oral dose, we need to take it with something on your stomach to kind of give a little protection. Enteric coated, the only NSAID that I know of that's enteric coated, and that's going to be your salicylates. You can buy aspirin enteric coated, okay? Typically, it'll come, when it comes from the store, it'll have like a yellow label on it. And if you read on there, it'll tell you that it's enteric coated. Okay, it'll come up as EC on the back of the pill. With these patients, I'm always asking them, so tell me about your renal status. If I have a patient who's a chronic renal failure patient or maybe a chronic renal insufficiency, meaning that there are two labs, if I was going to look at the two labs that go with renal, I would look at, that's right, a BUN and a creatinine level. So if I look at their creatinine level and their creatinine levels start to kind of creep up a little bit from all the different times they've been either hospitalized or ER or whatever, then those patients I would recommend that they may not take an NSAID right away, okay, or that they don't take it for long term, that we just use it for a short-term dosage. Absolutely positively, we do not mix anticoagulants with these medications, nor glucocorticoids, nor alcohol, nor pregnancy. NSAIDs have been known, if taken during a certain time during pregnancy, is that they will close the foramen ovale. So the foramen ovale sits in a little baby's heart, and it's a little bitty hole between the right ventricle and the left ventricle, and it allows oxygenated blood to flow back and forth, which the babies need whenever they're in utero. As soon as that baby is born, that foramen ovale is no longer patent. Within the first couple of breaths and beats of the heart, it actually closes itself up. Okay. If we have a patient who is pregnant who takes NSAIDs, aspirin, ibuprofen, Aleve, we have an increased chance of that foramen ovale closing prematurely and the baby having heart issues. So we don't recommend it for moms. I do want to highlight a couple of our NSAIDs because you're going to run into them frequently in practice. Salicylates, aspirin, is contained in a lot of different products. a lot of products I don't think we recognize. So this is Excedrin migraine. Okay, I gave you the real picture on the top, but I always buy generic. And this one has acetaminophen and aspirin and caffeine in it. So this product contains a form of aspirin. This is our muscle patches that we got, and again, it contains a form of methyl salicylate. It's a form of aspirin. So a lot of those products may have hidden forms of aspirin in them that we may not be thinking about it. So one night I was working in the emergency department, and I was coming on shift for a day shift, and I took report from the charge nurse who was taking care of a patient in room 5. And she said, yeah, she goes, he was just here. He's in observation status. We don't really know what we're doing with him yet. We're just trying to wait for his heart rate and everything to come down so that we can send him home. I'm like, okay. So I go into the young man's room, and he was in his mid-20s. And I said, good morning, how are you? And he goes, what? I can't hear you. And I'm like, okay. So I spoke up a little bit louder, and then I laid my hand on top of his arm, and it was just wringing wet. And he said, oh my gosh. He goes, I said, how are you feeling? He goes, well, I have a horrible headache, and I can't stop being dizzy. I feel like the room is just spinning on me all the time. And I'm like, what's going on? Something is wrong. What is wrong in here? I don't know what is wrong, but something is wrong in here. So did some more investigation, talked to the gentleman, called his family, and I said, hey, so what's going on here? Help me through the story. What happened? And they said, well, he's been kind of depressed, and he lost his job, and he's lost everything, but we have a real hard time supporting him because he's an alcoholic, and he abuses drugs, and anyways, and so he's coming to live with us now. And I was like, okay, so well, what happened last night? Like, kind of tell me. Well, his girlfriend broke up with him, and we're just trying to help him out. I'm like, okay, well, what were y'all doing last night? Like, what? They're like, well, we were at Walmart, and Mom bought him some medications for his headache. And I'm like, okay, well, what did she buy him? She goes, well, she bought him some aspirin last night. I said, has he had any other medicines besides that? And she said, no. And so got to looking around. I found the bottle of aspirin, and in fact, it was a bottle kind of like this. And in this bottle, there was 300 pills, except that when I got to the bottle, there was 10 pills left. So the patient had taken all of those in trying to overdose, but didn't tell anyone. And then when he started having bad side effects from overdosing, he came to the emergency department. So always check to see what drugs your patients were taking, and if there's anything that you can do to help make them better. The other thing you should know is that we don't give aspirin to children. I will tell you that whenever I was a youth, that was a practice, that we gave aspirin to children for fevers whenever they would get them. We had baby aspirin, and they were yummy and they were chewable. The reason we don't do that anymore is something called Ray's syndrome. So I gave you a link down here. This is a really cool website. It's free. I like it free. And it's called Osmosis. Osmosis. I always want to say Osmosis Jones. Sorry. It's called Osmosis. It'll give you a 6-minute video and does like drawings and stuff all about Ray's syndrome. So it's kind of something you can just go in and pick. But basically what happens is that children were getting aspirin, and then it was causing them to die from not from an overdose, but just because of the way that the medication reacted in the body when the patient had a viral episode. So you can read all about Ray's syndrome. So I told you you're never going to give aspirin to kids, except I know there's always an exception, right? There is a disease out there called Kawasaki's disease. It's an illness that affects small children. This is the only time you'll ever give aspirin to a kid. I remember going through nursing school, and my professors told me, you'll never see Kawasaki's disease. I've seen it twice in 20 years of nursing. I'll never forget, a small kid came in, he had Kawasaki's, been admitted down at Texas Children's, and came back through Bryan for something else. But while he was in the emergency department, it was time for his dosage of aspirin. His mom asked if we could give it, and I'm like, yes. I mean, we had an order from Texas Children, we had an order from the doctor, But it was just one of those moments as a nurse. I'm like, I was taught to never give aspirin to a kid. And then here I am with 81 milligrams of chewable aspirin, and he needed 8 tablets to make up his dose. Nothing about that felt right. And I went and I got my charge nurse, and I'm like, you're calculating this with me. She goes, Jamie, it's correct. I'm like, I know, but I'm just freaking out because you're giving a kid aspirin and then you're giving him 8 pills. This just does not feel right. It was all the right dose. It was the right thing for the kid. But again, Kawasaki's disease is the only time you'll give aspirin to a child. Ibuprofen, Motrin, Advil, I don't know why in the world ibuprofen has to have so many names. I mean, it's Motrin, it's Advil, it's everything. It confuses our patients when it's more than one thing. So with ibuprofen or Motrin, I wrote on here dealer's choice. So what I want you to remember about most NSAIDs is that most NSAIDs tend to work better for some people. So some people, Advil or ibuprofen is going to work better than, say, naproxen sodium, okay? So it's dealer's choice. If a patient tells you, I can take Advil all day long, it didn't work, but if you give me 2 Aleve, that's the thing for me, then you'll be like, okay, thank you, here's your Aleve, okay? So just to let you know, again, a lot of these side effects should not surprise you. We tend to have less gastric bleeding with ibuprofen and than we do with aspirin, and we also get less platelet aggregation. So in our aspirin, we give it to those patients, sorry, I'm going to turn my phone. Those patients, their platelets don't stick together as readily. And we do think that this is a little bit safer to use with anticoagulants. With children and adults, we have different dosagings and sliding scales for them, something that you just got to keep in mind. Remember, sometimes the products that we're buying are multiple products. So it may have acetaminophen in here, it could have ibuprofen in here, it may have guaifenesin in here. So whenever we have these multiple products, we have to think about that when we're calculating up how much kind of dosage can a patient have in a 24-hour period. So if they're taking more than one drug at a time, we really got to pay attention to those labels. And we've got to teach our patients, moms, dads, aunts, uncles, whoever's giving the babies medications or taking medications for themselves, to look for these multiple product names so that they don't overdose on them. Naproxen sodium, not used in children, definitely used in adults. It does have a longer half-life than our Motrin, so the great thing there is you get decreased dosing. We find that this medication, Aleve, also naproxen, also known as Aleve, is really great for teenagers with dysmenorrhea. The problem we have with this is that you have to get the patient to take the medication prior to the onset of their menstrual cycle. So you have to have them map it out on a calendar, and then we want them to start taking Aleve at least 2 days prior to the onset of their menstrual cycle, okay? If they do that, we have a lot less issues than if they don't. It'll work better for them, okay? I brought this one up, Ketorolac Toradol. I wanted to bring it to your attention because as a nurse who's in primary care or working in the hospital, we tend to see this one very frequently. It's given for a very short term. In the hospital, I see it given a lot for IV and IM dosing. It's really enjoyed a comeback as a favorite medication, especially since we're not giving out as many narcotics or opioids as we were in the past. So I want to tell you 2 weird things about this medication. So the makers of Ketorolac, and I don't know why they did this, there are 2 different vials of Ketorolac. There's a 60 milligram vial and a 30 milligram vial. When you look at the 60 milligram vial, it will say IV only. And when you look at the Toradol vial, or the Ketorolac vial, that's the 30 milligrams, it'll say IV or IM. Okay, so I've looked it up before, and there's some sort of a way that the drugs are chemically different. So the 60 milligram vials are only IV versus the 30 milligram vials, which are IV or IM. So just pay attention whenever you pull those vials out of your medication dispense system, that you're paying attention to say, what's going on here? Okay, hang on. Okay, so typically we give 60 milligrams IV, but we can give 30 milligrams IV or IM. Okay, typically an oral dose of ketorolac is reduced to 10 milligrams, and that's the reason why it is. But typically short-term therapy, we will see it in the hospital after surgeries. We'll kind of give them a preemptive dose of this NSAID so that they're decreased their pain, their inflammation in the long run. So our second generation conversation is going to be kind of short. There's only one drug in the class. Woohoo! You only have to learn one drug for one class. There were several other medications that were in this class, but what happened is that those medications actually increase heart attacks and increase strokes. So I have a theory about this, and I'm sure you'd love to hear it. So my theory is that there were other drugs on the market, Vivox being one of them, that what happened is whenever those patients started taking the medications, they were mainly elderly people or people with chronic disease. When you go back and you read the studies of who it increased MIs and heart attacks in, it really increased in elderly and patients who had chronic disease, multiple sclerosis, cystic fibrosis, those sort of patients. I think what happened is when they started taking those medication, it destabilized the plaques that were already formed in their body. It actually, the inflammation kind of like, oh, no more inflammation, and it released the plaques that had been building up, and then that's what traveled around and made things happen. So I have a sneaking suspicion we'll see something come back in the next couple of years as far as like a new set of COX-2 inhibitors, but we'll just have to wait and see. I bet they'll be deemed for special populations. Corticosteroids. Corticosteroids, we have already kind of spoken about previously when we talked about, we'll talk about them frequently with asthma patients, we talk about them frequently with our COPD patients. So when we give someone a corticosteroid, remember that's going to be an all over systemic effect. It's going to fix all of this, getting the full inflammation all over this body. The problem we have is that when we give a corticosteroid to a patient, it does go everywhere. And the adrenal glands that are supposed to be making our normal steroids, they just get kind of lazy. And they're like, well, if you're going to come in here, then I don't have to do my job. So it's real important that when we have corticosteroid therapy going on with the patient, is that we think about that their system, their inflammation system may not be responding appropriately or normally, and it's kind of suppressed. Everything's just kind of pressed down and suppressed. So because of that, whenever we think about someone being on a steroid therapy, we need to think about that their bodies aren't responding normally to infection. So we get all these little hidden infections that could be going on that the body's not responding to normally because we are suppressing it. We also know that this medication really only needs to be used for short term. I came across a patient the other day that was still taking like prednisone 5 milligrams every single day of their life. And I'm like, why? Why? He goes, for my COPD. I'm like, no. And we said we're going to switch him off. We're going to taper him off really, really slow over the next couple of days, weeks, and months so that we can get his adrenal gland to start working again and start giving him a steroid that's like an inhaled steroid, not putting in steroid all over this beautiful body. We're just going to put the steroid where it needs to be, not where it's everything. Patients who've been on steroids for a long term have a very particular look to them. It's called Cushing syndrome. And I'll show you a picture of it on the next slide. But with these patients, prednisone is going to be our main drug here. We're going to start on a high dose and we're going to taper them down. Again, corticosteroids for inflammation, short-term therapy. Because remember, inflammation is a sign of something else going on in the body. We don't want to continue to give this patient steroids all the time. They may feel great, except that it is not working great in the background for their body. You can see all the side effects there. This is a patient with Cushing syndrome. I will tell you, hands down, I can go to Walmart, I can go to the mall, and I can be like, that one's got Cushing's, and that one's got Cushing's, and that one's got Cushing. And it may not be that they've got Cushing's because of taking long-term steroids. They may have Cushing's because of the actual disease Cushing's. But just to let you know, patients with long-term steroids, this is exactly what they look like, okay? I'm telling you, you can pick them out of a lineup like that one's got Cushing's and that one's got Cushing's because they all got this look to them. The other non-NSAID that I wanted to kind of just like throw out here, and that one is good old-fashioned acetaminophen. Remember, acetaminophen has a tricky little habit of having multiple names. So your patient says, yeah, I'm taking a great pain reliever. And I'm like, well, are you taking Tylenol, acetaminophen, what? And they're like, no, I'm taking a pain reliever. And then when you read the signs, it's acetaminophen, okay? So teaching our patients to read the generic names is very, very important. This medication is metabolized by the liver. If you have an overdose, we do have an antidote. That antidote is known as acetylcysteine, also known as Mucimus, and that thing smells like rotten eggs. It doesn't matter if you drink it or you give it IV, it smells like rotten eggs. We do have a limitation on the amount of acetaminophen that we can give. 3.5 grams is the newest recommendation. And the reason we had to go to a lower recommendation is because there's so many different products that contain acetaminophen as part of the product. So even though it says cold and sinus, there may be acetaminophen in there. This is the Excedrin migraine headache. It's got acetaminophen in there. So having teaching our patients to be savvy about the amount of medications that they're taking, the types, makes a huge difference, okay? So nursing process. So when I think about giving a patient a medication for pain or for fever, I think about a couple of different things. Number one, I always want to know what's the hidden beast in the closet, what's their past medical problem, what's their past surgical history. I want to know if they're pregnant. Again, I don't want to give NSAIDs to any patient that is pregnant. I don't want to give a patient medications to any baby that may be breastfeeding because they can pass it on. Social history. On this one, I really think about drugs. I need to know as a nurse, and then also too as a provider, have you ever had any issues with opioid medication or prescription abuse? I need to know that because as a nurse advocate, if I had a patient who was hurting really bad, and then all of a sudden I'm going to my doctor and I'm advocating for morphine, I am turning on those opioid receptors again, and I can lead them back down a trail where they may or may not be able to recover from. It may put them back into a narcotic crisis. I need to know their baseline vital signs. These medications that we talked about today don't really affect heart rate, pulse, or blood pressure. But if I have someone who's in pain, I'm most likely going to see an elevated blood pressure and a little bit of tachycardia and an increased respiratory rate. And then whenever I give my medicines, I may not get complete and total pain relief, but I may be able to decrease the pain some. So I try to get this pain scale going. You know, on a scale from 0 to 10, 10 is the worst pain you've ever experienced and 0 is no pain. Where's your pain at? And I'll tell them, I'm like, you know, with products like ibuprofen, products like Tylenol, I can really move their pain levels down 1 or 2 levels. I may not get down to 0, but I need to get down to a tolerable level of pain. At the same time as I'm trying to get them down to this tolerable level of pain, I can be doing these other things. The ice bags, the TENS units, the bracing, the compression, all of those things seek to help to relieve patients' pain. Salon pause. Again, I tell my patients, I'm like, I know you're uncomfortable. I would like to try to offer you some pain relief with an ice bag. I'm going to offer you some pain relief by applying a splint to your whatever, okay? When I think about labs from the nursing process, I think about the renal labs, which are their BUN and creatinine, good job. And I think about the liver labs, which are your AST and your ALT. I think about having those 2 sets of labs in my brain so that I know that if I have a patient who has renal issues, giving an NSAID may be not a good idea. If I have a patient who has a history of liver disease, giving a patient Tylenol could be a bad idea. When I give these medications, I want to know, did they have any kind of weird side effects? We know that with NSAIDs, that those medications can typically cause you to have gastric upset. So we want to make sure that we're having our patients eat something before they take them. And then I want to know, like, okay, if your pain started off at a 10, are we at a 7 or an 8 now? Again, we're going to bring this pain back down in incremental segments. So we're going to keep assessing that. Then 30 minutes after I've given the medication, especially if it's a child or an adult who's got a fever, I want to reassess 30 minutes after I give that dose to see where we're at. Remember with children dosing that we always use an appropriate device, okay? We never want the mom or the dad to go grab a teaspoon from the kitchen. We want to send them home with a oral syringe, okay? And this is an oral syringe because it doesn't have the lower lock on it. It's just got the tip on it. I want to know about adverse reactions. Again, would I expect someone who took a NSAID to have a little bit of a tummy upset? Yeah, that's a side effect, but I wouldn't want them to break out in hives or have an incredible rash. I always want to think about what was my intention. Was it to bring the pain down, the inflammation down, and how does this patient feel now? With safety concerns, I will tell you that educating our patients about combination products and getting them to recognize what products are in the medicines that they're taking is a huge step for me in the patient's safety, especially when they go home and begin to treat themselves at home with different medications. So that's my biggest safety concern. All right, guys, that is everything for the pain and inflammation. We will talk more about these medications. The great news is that some of these medications are going to keep coming back up in a lot of repetitive lectures just because we have so many uses for so many of them. So thank you guys for listening, and I'll talk to you soon.